Yeah, so great question. So our group has been really fascinated with this kind of general question of kind of really how does the cardiac system interact with other core systems that are very important for overall death and disability and that risk. And previously in our group, we've explored linkages between chronic kidney disease and heart failure, showing important bidirectional associations. And we know that diabetes is a very strong risk factor for heart failure, but whether or not actually heart failure can be an important risk factor for diabetes is a question that's highly underexplored. And so that's exactly that exact question was really the frame for this analysis. And I think the key, I think, processes by which heart failure might contribute actually to incident or new onset diabetes is it's likely multifold. I would say that heart failure in general is because there are shared, I would say, underlying drivers of both heart failure and diabetes simultaneously, such as obesity, which is a core risk factor for both conditions. There's strong overlap in the underlying risk factors for both. And so you could think about heart failure almost as being a kind of a high risk entity for development simply because the underlying profile of risk is very similar to those who develop diabetes. But it's actually interesting that heart failure events we felt actually might contribute directly to diabetes for actually through pathways that have actually been well known for over 100 years. It's been well established that individuals who have acute illness, especially acute critical illness, actually have upregulation of systemic inflammatory pathways. They have activation of certain hormones in the body, like cortisol, that can contribute to derangements in glycemic control, and additionally have important upregulation of hormones like adrenaline, which can additionally also contribute to the resistance of insulin on the tissues of the body, which is really the major hormone that regulates the amount of glucose in the bloodstream. And so we actually felt that because heart failure was characterized by or heart failure events can be characterized by the same upregulation of all those pathways that can promote diabetes. Our kind of core question was whether or not heart failure events in the FINEARTS trial are associated with diabetes. And we did find that although most events actually of new onset diabetes did not occur after heart failure events, we found that heart failure events increased steeply actually after heart failure events, indicating that kind of those periods of acute stress are currently potentially important, but also under recognized opportunities for diabetes detection and management. Yeah, definitely. And so I think there are potentially two parts to that. I think, and so if we just take individuals with established diabetes at baseline, we've done so FINEARTS included both individuals with and without diabetes. And what we previously have shown is that individuals with diabetes at baseline and without diabetes at baseline derive very similar benefits of finerenone on the primary endpoint, which was cardiovascular death or heart failure events. And so baseline diabetes status does not appear to impact the benefits. Both groups benefit substantially. And then there's this other important question, which is what happens actually, what is the impact of finerenone on diabetes? And so we've done prior work actually showing that finerenone notably substantially reduces the risk of developing diabetes among individuals with heart failure, which was very interesting to see ultimately. And the underlying mechanisms for that, I would say, are a little unclear. And that was one of the things we were exploring actually in this analysis. What are the potential pathways for that benefit? And so, and and what we additionally found in this analysis was that that benefit of finerenone on incident or new onset diabetes did not appear actually to be modified when we accounted for the heart failure events. Because some people might say, kind of back to that kind of core question of if heart failure events are associated with diabetes and finerenone reduces those heart failure events, is it possible that finerenone actually could reduce diabetes just because it's reducing those events that can promote diabetes? And what we found was that actually that was not the case. And that's consistent again with most cases of diabetes occurring among those who did not have heart failure events. And so it suggests, I think, a couple of things. I think that there are important benefits of finerenone potentially on several different organ systems. And I think that we're still attempting to disentangle the precise nature and the breadth of those potential benefits. But I think showing the benefits of finerenone specifically on heart failure events suggests that there are important benefits that are specifically targeting the pathways by which heart failure can progress over time. Part of that actually can be kind of reductions in the amount of fluid in the bloodstream, kind of reducing congestion. And the other pathways by which we really feel actually there's probably a substantial benefit, but this accounts for some benefits that evolve over time, is that finerenone especially likely has substantial benefits on fibrosis or scarring in the organ systems, and that can help the heart to relax and also help the heart to function. And those effects might be actually occurring both in the heart as well as in the kidneys. And so those are two pathways by which I think we might see substantial reductions in heart failure events or progression. The impact, though, on diabetes is especially interesting because that suggests there might be additional metabolic benefits. And I would say that there is some precedent for that. There have been prior trials that haven't specifically targeted the same exact pathway, being aldosterone signaling, as finerenone, but other agents, for instance, like losartan, which is an angiotensin receptor blocker, in the large-scale Navigator trial, which was published 15 years ago, also showed actually reductions in new-onset diabetes. And so it could be that there is some general effect on aldosterone signaling or on RAS signaling. It's also theoretically possible that actually preventing low potassium levels, which we know can certainly occur with finerenone, which might be an important benefit, that preventing low potassium levels actually might be another core mechanism by which finerenone can actually have these additional benefits. Low potassium levels can be associated with impairments in insulin release, kind of an impaired sensitivity of organs to the effect of insulin. Yeah, no, it's a great question. I would say, and so finerenone, I think FINEARTS was relatively unique in that it included individuals actually across a broad range of care settings. Specifically, though, individuals could be enrolled in the trial if they were hospitalized or recently hospitalized, and also individuals could be enrolled simply in routine care, insofar as they were still symptomatic and met the other eligibility criteria. And I would say that in studies that we've done, secondary analyses of the FINEARTS trial to better understand these profiles of benefit, the broad message really has been consistency of the relative effects, meaning that kind of duration of heart failure, for instance, underlying diabetes status, underlying kidney status, that all of these actually, all these important clinical characteristics, and even things like age and sex, do not appear to modify the benefits of finerenone. And so it suggests that really finerenone is effectively an equal opportunity for individuals to actually reduce the progression of heart failure and improve their symptoms and potentially in quality of life. And that, I think, is the first important message, that we see broad consistency for heart failure outcomes. Now, for diabetes, we're only kind of getting into this, but I think based on the preliminary work that we've done, I would say that there is potential actually for individuals really across the glycemic spectrum to potentially benefit. My suspicion is that those individuals who are at highest short-term risk for developing diabetes, these would be individuals, for instance, who have core diabetes risk factors like obesity, or who might actually have pre-diabetes at baseline. Those are the individuals that are typically at highest short-term risk for developing diabetes. And therefore, a lot of the signal that we see, not entirely, but a lot of the signal that we see actually in terms of who develops diabetes in the course of the trial, these are typically people with either pre-diabetes or individuals with substantial risk factors for incident diabetes. And so I think those are the individuals I think that would probably have the most short-term benefit. But of course, we suspect probably forthcoming guidelines may eventually recommend finerenone for long-term use, given its the recent extension, for instance, of its label with the FDA. And so there's the potential for even more or stronger enduring long-term benefits. Yeah, it's a terrific question. I think There's a fair amount to unpack there, but I would say the specific questions that I think we're really interested in is kind of in clinical care, what is the potential benefit of combination therapy? In prior studies that we've done, what we've seen is that kind of the underlying group of medications, for instance, that an individual might already be receiving to mitigate their heart failure risk, that underlying kind of those background medications don't necessarily appear to influence the benefits of finerenone. And that's an important message. It indicates that this historical profile, which we've seen in HFrEF, of progressively sequencing therapies and anticipating additive benefits, would likely also apply to HFpEF. But as you know, kind of HFpEF and HFmrEF, these are individuals actually for whom treatment options have been historically lacking. And so it's actually absolutely fantastic, but kind of this area of more uncertainty, that we actually now have multiple treatment options for individuals who are impacted by HFpEF and HFmrEF in clinical care. And so I would say that that this is a little bit still an unresolved question in terms of how these medications might interact. I would suspect there will be consistent benefits and additive benefits according to baseline kind of background medical therapy. And notably, we actually have other trials, mostly in chronic kidney disease, that have really highlighted the potential for exactly additive benefits. There was one recent trial called the Confidence trial, which was actually one of the first combination trials of an SGLT2 inhibitor and finerenone in individuals with chronic kidney disease and type 2 diabetes, and evaluated the core outcome of urinary albumin to creatinine ratio, which is a very important marker of kidney risk, but also a very, very important marker of cardiovascular risk. And the reductions actually with the isolated kind of either SGLT2 inhibitor or finerenone, or the combination, were actually almost exactly numerically additive. And that really supports actually that there are, of course, unique targets by which these therapies work, and the potential for truly additive benefits to improve outcomes.